distinct pleasure of introducing Dr. Sarah Sheppard as our next SPD Journal Club presenter. So Dr. Sheppard is a clinical tenure track investigator at the NIH in the Eunice Kennedy Shriver National Institute of Child Health and Human Development. And she is also a 2021 NIH Distinguished Scholar. She received her MD and PhD degrees from the University of Massachusetts, followed by a combined pediatrics and clinical genetics residency at the Children's Hospital of Philadelphia, where I had the distinct pleasure of overlapping with her. She then served as a clinical geneticist and was a member of the Comprehensive Vascular Anomaly Program during her postdoctoral research fellowship at CHOP. And now she's at the NIH, where she leads a translational research program that's focused on lymphatic anomalies with the goal of expanding therapeutics in this space. So we're really delighted to have you here tonight, Dr. Sheppard, to present her recent Nature Medicine paper on genomic profiling in vascular anomalies diagnosis and treatment. Thanks for joining us, Shara.
Oh my gosh, thank you so much for the really nice introduction, and thanks for having me here. Oh no, we're not advancing. There we go. Okay. So vascular malformations and vascular anomalies are malformations of the blood or lymphatic vessels, and these can cause really significant disability in patients. These are some of the participants that were in our study. And you can see these this was an individual with a microcystic lymphatic malformation of the axilla. Here is a venous capillary malformation. Here is a capillary lymphatic venous malformation. A patient with cloves, and then also here, this is an AVM, and you can tell there's some really terrible skin ulceration. And so, you know, these can cause, all these malformations can cause pain, and especially with the complex lymphatic anomalies, they can cause all sorts of effusions, and many of these can then lead to infection, and in some cases, really significant issues for our patients. And when we think about what we know about the genetics for these vascular malformations, we know that the PI3 kinase pathway and the RAS-MAP kinase pathway are really important and really the major contributors. And the reason that the genetic diagnosis is super important now is because we know that we actually have these precision therapies like alpelisib for PI3 kinase disorders, sirolimus or rapamycin, which is pretty much first line for most vascular anomalies at this point, and MEK inhibitors like trametinib or selumetinib for complex lymphatic anomalies, as well as AVMs, at least now in some single case reports and clinical trials. And one of the complicating factors in the genetic diagnosis of these vascular anomalies is somatic mosaicism. And so what I mean by that is that patients actually have a genetic cause for these phenotypes or these vascular disorders, but they're only present in a subset of tissue, which is here represented in blue. And so typically in the clinic, I'm sure many of you will take a skin biopsy of a capillary malformation and send it for genetic testing where they'll isolate genomic DNA. But oftentimes, if it's not a capillary malformation, we have to think about how dangerous it can be, or whether we can even access that tissue in terms of trying to get a genetic diagnosis. And so recent work has looked at cell-free DNA, which is essentially the DNA that's free-floating in biological fluids like blood or lymphatic fluid, to try to provide a non-invasive diagnosis. And so really the aims of our study were to define the fraction of participants that were able to receive a genetic diagnosis using multiple different testing modalities, as well as developing non-invasive methods to detect low allele frequency variants. And then finally, we really wanted to demonstrate what the impact was of having this genetic diagnosis on these participants' medical treatment. So these were all participants that were seen at the Children's Hospital of Philadelphia Vascular Anomaly Program. There were over 350 participants in our study, essentially equal sex, and the majority of the cohort was pediatric, though we did have participants up to 60. The participants were all evaluated by our multidisciplinary team to provide a diagnosis based on the ISFA, or the International Society of Vascular Anomalies for the study of vascular anomalies classification. And the majority of the cohort, the sort of the largest group, was patients with secondary lymphatic conduction disorders, or secondary CCLA, with primary central conducting lymphatic anomaly coming in second. And then other large groups included patients with lymphatic malformations and venous malformations. So for each participant that was enrolled after their diagnosis was determined, we then evaluated which test should occur based on their phenotype. So for participants with phenotypes that we thought were associated with a germline diagnosis, typically they had a routine exome sequencing that was genomic DNA from leukocytes. For those with somatic associated diagnoses, typically they had a deep exome or a panel. And that was from like genomic DNA isolated from affected tissue or from cell-free DNA. And so when we looked at the genetic diagnosis rate by vascular anomalies or grouping, we saw that individuals with vascular tumors had a diagnosis about 30% of the time. Individuals falling under the unclassified vascular anomalies had a diagnosis about 60% of the time. And those with vascular malformations, which included primary lymphedema, had a diagnosis over 70% of the time. Individuals with those secondary lymphatic conduction disorders very rarely had a diagnosis. And this could be because we think that these can be due to other issues, such as differences in pressure that may cause some of these conduction disorders. And when we looked at primary complex lymphatic anomalies, over 40% of patients were able to receive a genetic diagnosis, which is a significant improvement from a previous retrospective study that we conducted. And next, we also looked at the genetic diagnosis rate by the sequencing methodology. So we looked at routine exome for primary complex lymphatic anomalies because a major contributor can be germline RASopathies, such as Noonan syndrome, and found that there is a diagnosis in about a quarter of those patients. When we looked at routine exomes for other vascular malformations, so these were patients with that we might think may have a capillary malformation syndrome, such as CMAVM, or for example, HHT, those individuals had a diagnosis almost 100% of the time. Individuals that had deep exome and primary complex lymphatic anomalies had a diagnosis about a third of the time, and people that had deep exomes for vascular malformations had those about 75% of the time. We also used two different panels that we designed sort of custom in-house to try to increase our coverage. And those really had two different, 5 out of 28 had a diagnosis, and 57 out of 136. And so one of the aims of our study was really to try to use non-invasive methods. And so one of the ways that we did this was taking lymphatic fluid that was drained for another clinical procedure. So oftentimes patients with these complex lymphatic anomalies have chylous effusions or chylous ascites that need to be drained. And so this fluid was then centrifuged, and then we took the supernatant and isolated cell-free DNA from it. And then we took the cell pellet, and essentially what we did was try to culture the endothelial cells by plating them on fibronectin-coated plates and using endothelial cell growth media, and then using a CD31 magnetic beads to enrich for endothelial cells before isolating genomic DNA. And these we subjected either to deep exomes or to panels. We also looked at some formalin-fixed feraffin-embedded tissue, which is typically done by clinical laboratories as well, but with the caveat that you need to be able to have the tissue there. And those participants had a diagnosis over 50% of the time. When we looked at those endothelial cells that we cultured and isolated and cultured from lymphatic fluid, those had a diagnosis about 30% of the time. And when we looked at those individuals that had cell-free DNA isolated either from plasma or from lymphatic fluid, we were able to provide a diagnosis in those samples almost 40% of the time. And next, what we wanted to do is actually demonstrate how having these genetic diagnoses could actually affect medical treatment. And so a little less than half of the cohort actually was on some sort of medical therapy, such as sirolimus or trametinib or alpelisib. And when we looked at those participants that were on medical therapy, we then wanted to see how this genetic diagnosis supported their therapy. So for example, a diagnosis of something in the RAS pathway would support treatment with trametinib. And what we found is that the majority of patients that were already on, we had about 25 participants that were on some sort of medication where the genetic diagnosis supported it, and only one where it did not. However, this participant actually was improving on therapy, so nothing was changed. But really, I think excitingly, what we actually showed was that, in almost 20 participants and almost 30 participants, that genetic finding led to a change in medical therapy or to an initiation or considering an initiation of a new medical therapy. And so that's almost about 2/3 of patients. And then finally, what we did was we actually then looked at how did this medical therapy lead to improvement, or what was the results? And those are what we classified as either worsening, stable, improved, or mixed responses, with NA representing participants that had been on therapy for too short of a time to really understand. And you can see here that there leads to improvement in the majority of these cases. And I just want to leave you with the example of one of our participants here. This was an individual that had Kaposiform lymphangiomatosis, which is a complex lymphatic anomaly typically characterized by mediastinal involvement. There can be pleural effusions and really significant coagulopathies. And so this individual had a very significant coagulopathy. You can see initially his D-dimer actually was pretty high at 15. And then you can see once he started trametinib, so this is 0 and these are 1-month cycles, you can see that there was normalization of that. And then here we see the pulmonary function testing for this patient. So as I mentioned, this patient had significant pleural effusions. You can see with this at start of therapy, you can see really an improvement in all of these metrics, such as the forced vital capacity, forced residual capacity, forced expiratory volume in 1 second, and the total lung capacity. And just this is his imaging. So this is an MR lymphangiogram where you can see significant mediastinal involvement. And these are some of his effusions prior to the start of therapy. And then after therapy, he was really doing it really well, and you can see very minor effusions. So in conclusion, we developed some novel techniques, including isolating genomic DNA from endothelial cells and using cell-free DNA. And this actually allowed us to get down to a variant allele fraction of 0.15%. We were able to identify molecular diagnoses in 41% of participants with complex lymphatic anomalies. And this has been the largest prospective cohort of complex lymphatic anomalies. The molecular diagnosis rate was about 72% for participants with other vascular malformations, which is similar to those numbers that have been previously published in the literature. And we also demonstrated that a genetic diagnosis could lead to a new medical therapy in 63% of our cohort, and more importantly, an improvement in clinical status in 63%. There are also some other conclusions, which I didn't really have time to go over today, but you can definitely look at all of those in the paper. And I feel really, really fortunate to have gotten to work with really an amazing team at CHOP to do this work, especially Dr. Lee, who is my co-first author on this paper. And definitely a huge thanks to the patients and their families, because obviously they really drive all the research. As well as my lab members, especially Scott, who did some of the zebrafish work for this paper that I didn't have time to present today, all of our funding sources. And thank you so much for your attention. I will just mention that I have postdoc positions available. So this is my email in case you're interested. Thank you so much.
Thank you so much, Sarah, for that awesome presentation and all those cool insights that your paper found. For anybody who wants to ask a question, feel free to put your questions in the Q&A and then we'll present them here. But to get us started, you know, it's not that common that we get to have a pediatric geneticist on one of our journal clubs. So maybe we could pick your brain a little bit about kind of what, you know, your approach might be, right, from a genetic standpoint, as to kind of your algorithm for kind of pursuing genetic diagnosis and testing in a patient that walks in with, you know, a vascular anomaly, you know, NOS, like we're trying to figure out what it is, you know, what type of
Yeah,
testing, like what's first line versus second line. Be great to kind of get your insights on that.
yeah. I mean, well, I think it really depends, obviously, on what the phenotype is and whether or not you're going to want to take a biopsy. I really think that, especially for some of these disorders, like even if someone walks in with a capillary malformation, depending on how involved it is, um, I would say that Dr. Treat and I would typically vote for testing, and a lot of in most patients that would then walk into our vascular anomaly clinic. I think, you know, by the time that they've been seen, and you know, this is probably the bias, right? You have to think that the patients that have walked into to my clinic have already been screened by a dermatologist that thinks, okay, this is not just like, you know, the kid, this is not like my own daughter with a small articulated capillary malformation or something. This is something bigger, right? So maybe I have a bias there, but you know, I think there's some really, really nice clinical somatic panels out there. So if you're on the West Coast thinking about CHLA has a pretty big one now, actually, that's relatively new, with over 100 genes. I think it's VDM for kids. And they have like they have a really good program. Seattle Children's also has a great somatic panel. WashU has a great somatic panel, and so does Penn. So those are typically the places that I would send my somatic genetic testing. I think my considerations are always, the gene lists are a little bit different for all of them. So that really has to do with my consideration of where to send testing. And even, you know, I think probably someone might say maybe I was a little bit biased because it was a little bit easier to work with Penn when I was at CHOP. But for example, like for capillary malformations, the Seattle panel used to not have, I don't know if it haven't looked at the list recently, but didn't have AKT3. So if we were thinking about capillary malformations, typically we would send Penn. And the nice thing about Penn is if you have multiple samples, they will actually allow you to send 2 samples for the price of 1 test, which not other labs don't do. And so that's always really helpful. I think there's a really nice paper from Jimmy Bennett's group where they show that as you increase the number of samples you test, you actually have a higher likelihood of obtaining your genetic diagnosis for some of these mosaic disorders. That was in lymphatic malformations that they did that. So I think for those samples or those patients where you have multiple samples and you're not sure how good the samples are, that can be a really nice out. And then WashU, I think, is really wonderful in the sense that they'll really work with you with your patient's insurance. So for example, some insurances will only let you test a single gene first. So oftentimes they're one of the few labs that can do a single PIK3CA test, or at least they used to be able to. So
that's great. Thank you.
And
then what about kind of the specimens, like, you know, in terms of kind of what you would recommend us actually getting from the skin, you know, what size punch biopsies, more excisional biopsies, like, you know, I'm sure that as you mentioned, has an impact on yield.
Yeah, I mean, so typically, I again was really fortunate to work either with Dr. Treat or Dr. Costello when she was at CHOP. And so I think typically they were doing very standard, like 3 millimeter, 4 millimeter punch biopsies. Oftentimes, so we would just send them fresh. And then they can, you know, again, fresh is always better, or fresh frozen is better than formalin fixed. though a lot of the labs now can handle the formalin fixed paraffin embedded tissue. So, our sort of approach is like, if there's old tissue there, we kind of always go for the old tissue first, to try to save the patient a new biopsy, depending on what it is. And really now, I think some of the other exciting things are, Seattle Children's does, I did not mention this, but they have like a digital droplet PCR test for like very few variants, but there are some, like I think the Tech 914 for venous malformations, and some of the PIK3CA hotspot variants as well. And so that can be a really nice first line test if you have, for example, lymphatic fluid from a cystic malformation. Or I haven't tried it on blood yet, but I think it would be a good first test before trying a biopsy if you suspected a PIK3CA related disorder.
That's great. Yeah, and you had mentioned kind of the cell-free DNA testing methodology that you guys had looked at in this paper. Are there ways for us to send clinical samples to you or other labs, to kind of pursue this type of testing?
Yeah. Yeah. So so both myself and Dr. Lee are able to, we're able to take patients at the NIH, or, Dr. Lee and Dr. Connerson's study at CHOP are also able to take samples. Yeah, so feel free to email me if there's individuals that you're interested in. I think Dr. Connerson's IRB is very, very broad and can roll anyone with anything, where ours, I think, has to have a, I think mine at the NIH says has suspected vascular malformation or lymphatic anomaly. So, yes.
Great. Fantastic. And then just last question, I think it's really exciting is that you're able to show that, having a genetic diagnosis can certainly inform, right, the medical therapy that you might select for any given patient, and really sort of, embodies kind of personalized medicine, right, that we're all striving for. So I'm curious to know if there were any genetic changes that you guys found in your cohort where it led to a consideration of a novel medical therapy that perhaps is not on, kind of the typical radar for treatment of some of these anomalies, or and any any interesting sort of findings there at all?
Yeah. So we did have one patient who went on a BRAF inhibitor. So we found it sort of simultaneously with the clinical testing and with the research testing. Unfortunately, that did not really seem to help her. But she's, I think I think some of the hard parts about some of these older patients that have had multiple surgeries or multiple interventions, you don't really know if that's a result of perhaps they've had so many interventions. Now you've sort of scarred up all the area, and maybe the medicine can't access some of those areas of disease as well. Or is that, just a result of maybe the medicine, the dosage is not right, or the dosage needs to be higher, or like there's so many, I feel like an N of one that we don't really understand yet, and so many factors that we can't address. So hard to know, but that would be the only one that I can think of. And she was not on therapy at the time of this paper, so he was not included in this analysis.
Gotcha. Well, thank you so much. Thank you again, Sarah, for joining us for our SPD Journal Club. To sort of wrap things up, I think on all of our ends, I'm going to pass the mic to Dr. Eichenfield.
Thank you so much, Joy. Thank you so much. I want to thank all the presenters and the speakers for coming this evening. I also wanted to thank the third speaker. He was planning on coming. It was actually completely my fault, completely my mix up on my part. So I want to apologize for that. I know we were very excited to hear the third journal club presentation as well. Hopefully we can entice the speaker to come back for a different date. So thank you all for coming to attend. There will be a survey that's sent out tomorrow. Please take some time and fill it out so we can know and learn how we can better serve our community. And we also wanted to let you know that our next virtual journal club meeting will be on Thursday, November 16th at 8:30 p.m. Eastern Time, which is 5:30 p.m. Pacific Time. I think that's just about it. So we will wrap it up and have a great evening, everyone.